hierarchy of needs. Please, this is a priority for the NCLEX. You'll be using this for your prioritizations. According to Maslow, he said that you have to take care of your physiological needs before safety. And then from there, you think about love and belongings because before you think about self-esteem or self-actualization. What is most tested in the NCLEX is the physiological needs, and also they go all the way down to the safety and security. You will less likely be seeing questions on love and belongings and self esteem, and you will not even get questions on self actualizations. In this case, I'm going to be focusing more on the physiological needs. When we talk of physiological needs, what are they? These are things that help the body function. That's what we call physiology. Physiology is the functioning of the body. Anything that affects the way the body functions is a priority. Anything that threatens how the body is going to be functioning, we need to take care of them first. So let's look at what Maslow is saying. According to Maslow, we need oxygen. Oxygen is one of the main priorities in for the body to be able to function. And therefore, when a patient is having any situation that deprives the person from getting oxygen, it becomes a priority. It becomes a life-threatening situation. So anything that involves your airways, when airways are closed, is a priority. In case of anaphylactic reactions, it's a priority. When you hear the word wheezing, apnea, apnea near means breathing. Absence of breathing is called apnea. It becomes a priority. Stridor. In the case of pediatrics, we're thinking about retractions. So these are things that you cannot ignore. When we talk about airways, please, they are priorities. That's why when somebody comes from surgery, we pay attention to their airways. How are they breathing? Then we give them incentive spirometer to also help expand the lungs. But your airways, when you see anything that compromises the airways, you need to take care of that first before you think about breathing. Because when the airways are clogged, there's no way that even when you give your oxygen, it will go through. So anything that involves the airways, for example, when a person is choking, think about one, clearing the airways first before you think about giving them oxygen. If the question is not about airways and it's about breathing, breathing is getting oxygen in, which is the ventilation. We're talking about getting the oxygen in and out, carbon dioxide out. If the problem is about that, then you prioritize them as well when there's no airways problem in the question. In this case, you're checking their SpO2. If they were on room air and suddenly they start dropping into the 90s, goes into the 80s, this is a respiratory problems or these are breathing problems. We need to take care of them as quick as possible. You will hear new onset of confusion. This tells you that there's less oxygen going to the brain, and that's what we call hypoxia. Let's come to circulation. Circulation is where the person is actively bleeding. So after surgery, after we check the breathing, the airways, and also checking their respiratory status, we also focus on the person site of where the surgery took place. In this case, we're looking for signs of breathing. Let's assume that a person went for bronchoscopy, where a camera is taken into the person's bronchi and also try to visualize anything that's in there. When they come back, you are checking for bleeding. When they cough blood, it's a sign that they might be having some kind of perforation in there. You need to report that to the healthcare provider right away. It's a sign of respiratory problems. The same bronchospasms. When they come from the bronchoscopy, you are looking for bronchospasms. If the person start complaining of difficulty breathing and also start getting, let's say, stridor, these are signs that this person airways is being compromised. So this becomes a priority for this patient. You cannot ignore that. They came from the cath lab. You assess the site where the catheter was inserted. You assess it for bleeding. And then, when you have a GI problem where the patient is actively bleeding internally, you will see something like black tarry stool. Anytime you hear the word black tarry stool, please, before you choose any answer, ask yourself, is this patient on iron? If iron is not there, then that should tell you that they might be bleeding internally. And therefore, you need to prioritize this patient. In Bello, when the patient comes from any form of surgery and when we hear the word scant, moderate bleeding, those are not priorities. But when the person is actively coughing blood, hematuria, or anything that we think that the person is bleeding, prioritizing. Now, according to Maslow'S, when we take care of the ABC, which is airway, breathing, and circulation, we now think about our electrolytes. Most electrolytes that anchors love is potassium. When potassium is low, it's not good. If it is high, it's not good either. Either way, they will cause ventricular shrinkage. So usually we have this medication at bedside at all time to prevent the dyschemias. It is called calcium gluconate. Remember, calcium gluconate is not going to fix the hyperkalemia or the hypokalemia. The reason we have calcium gluconate on a bedside is because we don't want any ventricular spasms or ventricular dyschemia. Sorry, we don't want any ventricular dyschemias, and that is why we have the calcium gluconate. So we give the calcium gluconate to prevent the ventricles from going into dyschemias. Then we find ways to fix the potassium. If it is low potassium, prepare to give potassium. If it is not super low, doctor might order PO potassium. If it's critical, you have to transfuse potassium. In this case, the LPNs cannot transfuse that. It has to be the RN. Now, when potassium is high, one of the things that the doctor might order is IV insulin. In this case, we'll be talking about one insulin that can be given IV, and that is called regular insulin. So regular insulin is clear, it can be given IV, and then also help open the cells, then potassium will go back into the cell. So those are the things that I want to think about. In case of if the doctor doesn't want to use IV insulin, the other thing that the doctor might do is probably provide or give the person Lasix to pick out all the potassium. The other option we have is going to be K-exilate. This will help the potassium to come out as well. But in the case of the IV potassium, IV insulin, remember the main reason we want to get to the main thing we want to fix is the potassium and not the blood sugars. And so usually when the person is not hyperglycemic and you want to fix potassium, the IV insulin, the doctor will also order D5 so that we prevent the patient from going into hypoglycemia. This is critical thinking because normally when you are just giving the person insulin, you're going to be dropping. But in this case, it is not because the person's blood sugars are high. It's because potassium is high. And there's only one insulin that we can give IV, which is going to be the regular insulin. I will talk about that when we come to the metabolic system or endocrine system. The next one, which we have just called, is the acid-base balances. So when somebody is having diabetic ketoacidosis, renal failure, these are terms that we can prioritize them as well. Let's talk about temperatures. Think about infection. Anytime temperature goes up, for now, I would like you to think about infection. All this affect the way the body works. So when you see that is going up, think about it. We can also have metabolic problems going on. So for example, we can have hyperthyroidism going on. But I'm not going to go into that. But for now, think about infection when the temperatures are going up. Next is nutrition. This is where we think about severe dehydration and malnutrition, and then we take care of that. So if I have an airway problems, I'm not going to be thinking about nutrition. I'll take care of the airways first before I think about the food. Then elimination. Anytime we eat, we have to also get rid of the unwanted part. We have different ways to eliminate the waste products. One of them is the idea. So in this case, the person will be pooping, so we have diarrhea. And if the person is also having diarrhea, they can also cause electrolyte imbalances. Another way is going to be the kidneys. The kidneys are the ones that are responsible for getting rid of all the unwanted fluids out of the body. So, for example, so the person is having AKI, the creatinine levels are high, then we have a problem. No, always remember, if it affects airways, breathing, circulation, the answer is always that. Another way that I want you to remember after the physiological needs, then we come to safety and security. In nursing school, we have been taught that always safety triumphs everything. What you do not know is that this statement is actually true only in disaster management. When you are in the ICU and then you hear fire outbreak, it becomes a safety problem, it becomes a disaster. So then, whatever we are doing, you need to take care of the patient out of the way. We're not talking about airway breathing now. You need to think about safety. So just get this understanding. But as long as it's not a disaster management, your air comes first, your breathing follows, and then your circulation follows. And then the others will now go on and on. Now, to understand how to prioritize this patient based on ABCs, let us go to the second aspect of the Maslow hierarchy of needs, which is for safety and security. In this case, you'll be tested on fall. Some of the things that you have to do to prevent fall. We talk about putting the bed in the lowest position. Make sure that there's good lighting, so light is within reach. You did mention a lot, but look at some of the things that you have to put in place to prevent our patients from falling. When you come to infection risk, this is where you are using the proper PEs, proper PPEs, and also hand washing. These are the standard precautions that we have for every patient. Suicide risk, we're talking about mental health. Most suicide occurs especially in the depressive phase. When you have a patient that is bipolar, in the manic phase, don't think about suicide. Think about how to direct their energy to a productive way. You can ask them to go to the gym, but then your priority is going to be nutrition. So we give them finger food. And then with suicide precaution, think about placing the person on one-on-one observation. That is the best way to prevent suicide. But anytime somebody is suicidal, you have to ask some simple questions before you think about these suicide precautions. First of all, do they have a plan? If they don't have a plan, you ask them what their plan is. If they tell you that they are going to use a paperclip to kill themselves, you say, this is a bogus plan, it's not going to work. When they tell you that there's a loaded gun in the house, this is a very good plan. Think about it, we have to go get those guns. One of the things that a suicide patient will do to let you know that this person is at risk or they're going to do kill themselves, if there's a family history of suicide. Of course, he's not going to be the first person to commit suicide in the house. So in this case, or in the family, so in this case, the probability that he will do it is very high. If you see in the question where the patient has a history of suicide attempt, this also put them at risk of committing the suicide again. Think about when they are giving their belongings, things that they have worked so hard for, things that they value so much, they're giving them away. They were in the depressive phase, and all of a sudden, they come out so happy. There's a new form of energy. All of a sudden, these are signs that they have already found a way to carry on the suicide. In this case, you have to pay attention. There are times where they will send you text messages and saying that thank you for all the things that you've done for me. This means that they have found a way to end it all. So put them on the suicide watch. There are so many things that I can talk about as far as suicide is concerned. But these are just few things that I've mentioned. But in the questions, please pay attention to them very well because there are so many things that you can come out with. Let's come to isolation precautions. So we do not want any patient to what? We don't want to be infecting people on the unit. So we put them on precautions. There are three isolation precautions I want you to remember. One of them is airborne precaution. With airborne, think about your main PPEs. If it's TB, think about N95. Now, let's talk about contact precautions. With contact precaution, think about the enteric. See that? Measure. We're talking about MTR. That's multi-drug resistance organisms. VRE, vancomycin resistance. We have VRE, CDEF. These are things that you should be thinking about. Your main PPE is going to be your gown. Then you add your standard precautions, which is going to be your gloves and that of hand washing. Let's talk about droplet precautions. With droplet, think about the flu, think about whooping cough, and in this case, you don't see whooping cough in the questions, you see pertussis. These are things that I want you to understand, put them at your fingertips because they are going to help you. In this case, with a droplet precaution, you are going to put a mask on, which is going to be a surgical mask. Now that you know the isolation precautions that we have, let's talk a little bit about when you are transporting the patient. If the patient is in airborne isolation, as far as I know, or as far as you know, as far as NCLEX is concerned, when we are going into the room, think about putting on your N95. But if the question talks about transporting the patient from the room to any for a procedure, when you bring the patients out, you put the patient on the surgical mask. You, the transporter, do not have to put on PPEs. Again, with the TB patient, make sure you put them on negative air pressure room. If there's no negative air pressure room, you might see in a question that says HEPA filter. This will help, or these are the things that you should be looking for in the questions. Let's talk about skin integrity, like restraints and when the patient is confused. So when the patient is in restraint or a confused patient is in restraint, you check their skin just to make sure that they don't have any skin breakdown. Now, reporting domestic abuse or violence. With this, I want you to remember this. If it is a child, you have to report it right away. It's mandatory. The same thing if it is an elderly person, you have to report any suspicion of abuse to the social worker or you follow the facility protocol. But if the person has the mental capacity and they are of age, you do not have to report this. You have to get the permission of the person that is being abused before you report that. Let's assume that you have a patient who came to you with a husband. They came for a visit. Then you suspect that the husband is abusing the wife. Before you report anything, as long as the wife has the mental capacity and being able to make decisions, you cannot report that without the permission of the wife. In this case, all you can ask is that do you have a plan? If the wife decides to say don't report anything, you just have to ask that when things get worse, what is your plan? You can advise them on what to do. Right. This brings us to the end of the prioritizations. In this case, always remember ABCs first, then you follow the other ones, which is the Maslow. Always remember when you have acute conditions with the chronic conditions, you are going to be taking care of the acute condition first before the chronic. Like I said, I don't want you to remember anything or always remember what is before you. What you have to pay attention to is the diagnosis and what is happening to this patient now. We're talking about the modifying phrase. If you go to my clearance, he will tell you that pay attention to the modifying phrases. Let me give you an example. A patient that is COPD is on 2 liters of oxygen, sitting and watching TV with no respiratory distress. This is a chronic condition. He's already on 2 liters of oxygen. Interventions are in place. He's not showing any signs of respiratory distress. Even though it's a respiratory condition and it's chronic. The same COPD patient who is now on 5 liters of oxygen and is showing a sign of confusion or agitation, it tells you that the 5 liters is not enough with this, control, stabilizing this patient. So in this case, even though it's chronic, we also have some kind of acute exacerbation going on. That becomes priority. We need to take care of them right away. Next, anytime we hear new onset, severe pain, severe something, pay attention to them. New onset of confusion, pay attention to these areas. These are things that might be a priority that you have to take care of. Again, when the question talks about an unstable patient, pay attention to that. You need to look at them. They become a priority to be taken care of first. Like I regularly said in class, if you go to the ER, it is not about first come, first serve. What we do is that we do triage. So we have some people called triage nurses, right? So based on what is bringing the person to the hospital or to the ED, will determine when to take care of them and when not to take care of them. Now,